Hello, everyone. Thank you so much for sharing your time with us tonight. We at the Penn AERD Center are really excited to discuss AERD care with you and to answer your questions. My name is Mike Sonnentag. I work with the Penn AERD Center, and I'll be moderating this evening. We received many questions from across a variety of AERD topics, and here to answer those questions, we're joined tonight by Penn AERD Center Medical Director, Dr. John Bosso, and Penn AERD Center Surgical Director, Dr. Nithin Adappa. Dr. Bosso is a graduate of the Allergy Immunology Fellowship at Scripps Clinic, where the aspirin desensitization procedure was initiated and perfected and was one of the first to learn the technique. After fellowship, Dr. Bosso founded the first regional AERD program in the New York metropolitan area and is the most experienced AERD expert in the Eastern United States, successfully desensitizing over 1,000 AERD patients during his over 30 years in practice. Dr. Adappa is a graduate of the University of Pennsylvania Rhinology and Skull-Based Surgery Fellowship, one of the leading institutions on the management of challenging chronic rhinosinusitis and nasal polyposis, with a high volume of patients with AERD. Dr. Adappa has performed over 2,500 sinus surgeries, focusing on complete clearance of sinus disease, as well as therapies to minimize the recurrence of sinus infections and nasal polyps. Both Dr. Bosso and Dr. Adappa are preeminent experts in the treatment of AERD, with collectively over 40 years of experience. Dr. Bosso, Dr. Adappa, welcome.
Thank you, Michael.
Thank you, Michael. Thank you, everyone, for tuning in here. So we thought what we would do is we would start with everyone, in this new forum where we're not actually getting instantaneous feedback. We thought we'd kind of give a little bit of background of the genesis of our AERD Center, what our thought process is, what our evaluation process is. And then once we get through that, then we'd go through a number of the questions that were submitted. So basically, as Michael said, I am one of the rhinologists here. I work here at Penn with several other rhinologists, including Jim Palmer, Mike Kohansky, and David Kennedy. And we were seeing a high volume of essentially complex patients, typically patients that were sent in from the community to deal with complex sinus surgery. And as you can imagine, this was a high volume of AERD patients, both diagnosed and undiagnosed at that time. So when we started doing these surgeries, what we were doing then was we wanted them to get desensitized, but we really were looking for someone who had a lot of experience. So we struck up a relationship with Dr. Bosso, who was in Nyack, New York at the time, which Nyack to Philly is about 2 hours drive. So you can imagine it was a little bit challenging. We had patients driving a little ways to get to us. We'd then do the surgery, and then we'd coordinate with him desensitization, which they'd be seeing him in Nyack and doing that. So in 2016, after several years of trying to coax him over to our neck of the woods, Dr. Bosso agreed, and he joined our division as the medical director of the AERD Center. And all of a sudden, things completely changed for us, where we essentially have our rhinologist and Dr. Bosso in the exact same corridor, same room area, seeing patients together. So essentially what happens then is if a patient comes in or calls in for AERD evaluation, in most situations, they'll actually see me as the surgeon and Dr. Bosso as a medical allergist and AERD specialist together on the same day so that we can essentially get a full picture and then we can discuss cases together. So typically from my end, and then I'll let Dr. Bosso go on his end, but typically from my end, when I see a patient, the things that are really important to me are, number one is how long has this been going on, and have you had any surgical procedures, and what are you using topically from a therapy standpoint? And then we typically take a look with endoscopy, and we have a nice setup in our offices where you can also, if you want to, you can see what your nasal cavity looks like. And we'll either have a CT scan beforehand or our in-office CT scan. We'd get a CT scan right there. And we'd really be able to evaluate the extent of your prior surgery, how the polyps are looking, and things of that nature. And once that happens, we then have you get evaluated by John, and he can kind of go into what he's looking for from his end.
Thank you, Nithin. That's a really nice intro. And yeah, it's been very nice synergistic relationship coming here to Penn, working together side by side with surgeons with their their perspective is a little different from my perspective, having trained as a medical person, not having the anatomical background that the surgeons have. Find that our skill sets really do meld well together to make this a positive relationship and also a positive experience for the patient, because they're getting kind of two perspectives on a condition that's always been very difficult to deal with. So what I'm looking for is I'm going to take a comprehensive history on any patient that comes in from the medical side. I want to see for sure, do they have AERD? And if there are any doubts, we're going to be setting up an aspirin challenge when that's appropriate. Some of these patients don't have AERD, but they have conditions that are very similar, that mimic or that may masquerade as AERD. And so that sometimes becomes the challenge. And so we also deal with those patients. We also take care of those patients. But it's important that we get an accurate diagnosis, both anatomically and also medically. And I think once we have that, we can move forward with a plan. And that plan, in most cases, will include aspirin desensitization after a complete surgery. And when I mean a complete surgery, he really didn't talk too much about how well the surgery is done here at Penn. But one of the reasons I came here is because I was seeing such outstanding results. And we knew that there was something special about the type of surgery they were doing that starts the process at square zero and sort of gets you back to a total baseline. And I found that the patients who were having their initial surgeries by these surgeons at Penn were then in much better shape to have a medical plan presented afterwards, which is usually now aspirin desensitization, because it's something I've worked with for the most years, and we've had such excellent results. We've had 90% of our patients who stay on aspirin for at least 6 months will not need surgery again. And so that's often, a great response. And we've published that. And we do have some patients who don't tolerate aspirin. We have some patients who don't do as well as we'd like on aspirin, or can't go on aspirin for pre-existing medical conditions. And fortunately now we have biological therapies, which, although they haven't been as well studied for AERD, are at least available for some of the refractory cases. And we've had some good fortune with our difficult cases using some of the newer treatments. So I think as time goes on, we're going to have more available to us, but we're working with what we have. And I think we're maximally working with all the available therapies, both surgical and medical, and trying to combine them and start them at the right time and kind of intermesh those together so that the patient gets the best result. And I think a lot of that's just working together, communication, timing, and having the experience to know what works and what doesn't work for individual patients. As I said, one size doesn't fit all. Not everyone can be treated the same way, but we do have a model, and we also have alternative therapies. And again, not everyone gets surgery, not everyone gets aspirin desensitization, but most patients do pretty well coming out. And we also follow the patients, which is something that following the patients together is one of the things we do really well, because if there's a problem or a glitch or an issue with someone who's not really going along the path that we'd like them to go along, that's when we'll sit down and discuss the case and find out why or what else has to be done to get that patient really smoothly controlled. And that's kind of the beauty of the center, is that not only we're not done after we do our procedures, we're going to make sure that if there are any bumps in the road afterwards, that we smooth them out. If doses need to be adjusted or anything needs to be changed, or we find that something needs to be touched up in some way, that's what we do. And I think we do that really well as well. And that's just as important as doing the initial treatment. So that's our philosophy, is working together, a team approach, this whole using the best of both skill sets for the patient. And I think that's been working. I mean, you can certainly we have many patients who are happy and doing well in our program. And when they're not, if there's a problem, an exception to the rule, we look at those cases and we examine them and we say, what's gone wrong and what can we do better? And so I think that's something that we'll continue to do.
Thank you, Dr. Bosso.
Michael, I was going to add, I think that coordination component is sometimes not recognized, but it is, that is really a critical component for us. We know when I book a patient for surgery, John has already checked in with them to optimize their lungs to make sure they're completely safe for surgery. When a case is scheduled for surgery, they've also got their desensitization dates already scheduled. So literally the whole thing is set up algorithmically so there's no delays in getting desensitization later. Their lungs weren't optimized beforehand, that they're struggling, things of that nature. And then it goes through. And then like John was saying, we typically afterwards, all my patients, so I typically see patients on Wednesdays. All my mutual patients with Dr. Bosso and myself see him on Wednesday. So they see him, they see me post-operatively. So if there's any questions, he'll pull me into the room or I'll pull him into the room. And we've got the other rhinologists on different days who also, they'll have their day that their patients see John and see them on the same day. And that coordination really makes a difference. And we've actually got a paper that's out for review right now where we actually looked at our results when John was in NIAC and we were here, and our results were really good. And we then, after he came here in 2016, we took a look at our results of when we were all together, and it blew my mind. It stepped up another level that we actually didn't think it could. And really, I haven't changed my surgery. He hasn't changed his desensitization, but that coordinated care, I think, in tough disease processes makes sense. And that's why, for those of you who hear like things like cystic fibrosis, there's a reason they have CF centers, that they've got a number of people coordinated together. They're realizing on complex disease process, if you have coordinated care, you will get better outcomes. And I think for those of you who are looking for someone for AERD, wherever you are in the country, you want to look, in my opinion, for a coordinated center that really can put those two pieces together. Like, our results went up dramatically even after doing that.
Thank you, Dr. Adappa, and thank you, Dr. Bosso. I think that is a really terrific overview of the approach to care here. And now, we're ready to hop in and answer some of the questions that we received. So the first grouping of questions are around what is AERD and what are the causes of AERD. And our first question for Dr. Bosso is, what is known about the cause and mechanism of AERD?
So we don't know at all about the cause and the mechanism of AERD. We're still looking for that. That's still a subject of lots of research, but we do know a lot more than we know when I started out. So we don't know the exact cause, but we do know what actually starts happening to a patient when they develop AERD. What happens is somehow exposures that break down the lining of the sinuses, the sinus epithelium, the first layer of epithelium of this, it's our first barrier to the sinuses. When that epithelial barrier gets broken down, whether it be through exposure to environmental tobacco smoke, a virus, allergens, a change in the microbiome, which is basically the flora of the sinuses, something that changes, that breaks down that first layer of protection that your immune system has for the sinuses. When that happens, an alarm goes off underneath the epithelium. You get the release of certain chemicals that we call alarmins, and they are what are known as the innate immune system. So that innate immune system, what it does is it then bridges over to other cells that stimulate an immune inflammatory response. And that inflammatory response, unfortunately, continues unabated in some patients. Now, that's where we don't really know. Why does it go on unabated in some patients and never stop? And why is it easier to control in some people? And then why do some people go on to AERD? That's quite not what we know. We know with AERD, there are three key components to what's going on at the cellular level. Once that barrier's been breached and the immune system has been activated, mast cells are activated. Mast cells are cells that actually stimulate many other cells to get active and start with an immune inflammatory process. And then eosinophils infiltrate into the tissue, and they cause damage to the tissue. And then lastly, you have what's called leukotrienes, which are chemicals that are released by some of these cells that are upregulated. They're produced in tremendous quantities, and they cause further damage to the lining of the cells, the blood vessels, and the tissue. And so this inflammatory response and the receptors for the leukotrienes are also stimulated. So those are the three key components of what happens. Of course, why people get it is probably not one single cause, although we are looking at things like viruses. We're going to talk about research later, but we're looking at what might be the predisposing factors or the factors that start the process. And what often happens is that the immune system doesn't get the memo that whatever initially came and started to break down the lining, it may not be there anymore. It might not be a problem anymore, but the immune system doesn't get that memo. And it continues to cause this inflammatory response that just keeps going on and on and on. And that's why it's such a difficult process that just snowballs and becomes very, very challenging to deal with. And that's really the inflammatory process is probably one of the strongest sinus inflammatory processes of all the chronic sinus diseases. AERD is certainly one of the most challenging to deal with because of that strong immune response.
Thank you. How important?
Hold on. I'm trying to look through the chat events. There's some great questions on here. Sorry guys. These meetings I've realized the chat event and trying to talk is a little tough. But a good question was for John: is the disease a result of immediate barrier breach, or is that something that happens earlier in life over time?
Repeat that question.
The breakdown in the cellular barrier, is that something that happens immediately at that time, or is it something that's happening earlier in that process and just progressing?
It's a progressive process. It takes time. It doesn't happen all at once. So it is something where perhaps it takes several knocks on the membrane, on the epithelium, before the epithelium breaks down. For example, in situations where someone was exposed to, we know there's about a threefold increase in getting AERD if you are exposed to environmental tobacco smoke. But it doesn't happen overnight. It's a repetitive insult. Now, sometimes we know about half the patients will come to us and say, hey, I was perfectly fine until I got this really horrible flu-like viral illness. And perhaps that virus was such a tremendous stimulus to break down the barrier, and then the process starts. But the process it's not like an immediate thing. It takes time, and it sort of gradually fuels, and the patient sort of gradually gets worse over time. And so I call it's like a snowballing effect. It starts, it continues, it perpetuates, and as time goes on, it just gets more and more difficult to treat. So the truth is that, it's not a one and done real quick within a week or within a few days. It's over a period of months and a few years actually before the disease completely evolves to its full capacity. Good question though.
Yeah. Great question. The next question also for you, Dr. Bosso: how important are eosinophil levels in AERD, and should this be monitored?
So they're somewhat important. I mean, I don't monitor them anymore once a patient's doing well, and I'm certain that they have AERD and they're on the right treatment. I find that we're always going to be high. They're always going to be somewhere in the range of 400 to about 1,000 is where most patients stand. I start worrying about them when they're maybe over 2,000, certainly, because there can be other complications, such as coronary vasospasm, such as potentially going on to become like an eosinophilic granulomatous polyangiitis, a vasculitis. So there are some cases where we watch those, but once we're certain that the patient has AERD, eosinophil counts are not ridiculously high, they're going to be moderately high in almost all cases, unless you're on a biological medication that makes eosinophils go to zero, or if you're on prednisone, the eosinophils will go to zero. But outside of that, patients can do very well. I ignore them after a while. They can do really well on and have a moderately elevated eosinophil count, and they can still have no sinus disease, controlled asthma, and not having any issues. So I don't get totally bogged down with it. When I'm first working up a patient, I'll consider that as one piece of data and make sure that I have the right diagnosis. But again, once a patient's doing well, I don't watch it anymore.
Thank you. The next question also for you, Dr. Bosso. What role do mast cells play in AERD?
They're a central cell. In fact, the research I did when I was in training had to do with the mast cell's involvement. We show that the mast cell is involved very, very intrinsically in the process. It's a mediator cell between the innate immune system, which is what I talked about, those alarmins that come off the epithelium, and the adaptive immune system, where you have this central, the eosinophils, the ILC2 cells, and all these cells that release all these inflammatory cytokines that cause all the misery that patients have. But the mast cell is kind of a bridge, and it connects to many other cells and stimulates and has sort of crosstalk with a lot of these other cells, and is basically releasing leukotrienes, stimulating eosinophils. It's doing a lot of things to perpetuate the process. So it's kind of a middle mediator. It's sort of like the person in the middle of the soccer field that plays in the center of the field and is going back and forth all the time. That's what I think of as the mast cell in this process.
Thank you. Dr. Adappa, a question for you. Have you found that there is a correlation, and what is it, between sinus issues and spontaneous CSF leaks?
Yeah, I thought this was an interesting question. So CSF leaks or cerebral spinal fluid leaks, there actually is not any correlation there at all. So we see spontaneous cerebral spinal fluid leaks, and I'm not going to go too much into the weeds here, but there's a condition called idiopathic intracranial hypertension where patients have higher pressures of their CSF fluid in their brain. And over years and years, that pressure beats on the weakest area of bone, which tends to be the sinus area. And then you can break out and essentially have CSF that you're draining out that ultimately needs to be fixed. There's no correlation at all with chronic sinusitis, AERD, or otherwise. There are some forms of nasal polyps, something called allergic fungal sinusitis, that can sometimes erode the bone to the brain. AERD does not tend to do this at all. And even that condition we're talking about, even though it erodes the bone, there are still some other layers that are intact, so you just really don't see spontaneous leaks. Now, could someone have both spontaneous CSF leak and AERD? They could. I mean, it would be horrible luck because there's no association whatsoever. But it could technically happen. So if you are having a lot of drainage, especially unilateral, although AERD patients do tend to have a lot of mucus, if it is unilateral, completely clear, it's probably worthwhile just getting it tested. Any ENT, if you collect the fluid, can send it off from a test called a beta-2 transferrin test, which is very accurate to test for that. But again, it's very unlikely to have both together.
Thank you. Another correlation question, this time for Dr. Bosso. Is there any correlation between vitamin D levels and AERD?
We are studying that here at Penn, but I could say that there probably is, because AERD is associated with elevated eosinophils both in the tissue and in the peripheral blood. And there is a correlation between vitamin D deficiency, not insufficiency, but deficiency, which means significant reductions in vitamin D levels, and peripheral and tissue eosinophils in chronic sinusitis. So although we haven't shown it specifically for AERD, I'm expecting that we will find that we don't know if it's going to be more severe than patients who have other forms of eosinophilic sinusitis, but I think it'll be higher than other groups that we may look at. So I do think that there is some correlation. Perhaps not proven with AERD, but I get the sense that I tell all my patients to have their vitamin D levels checked. If they haven't checked, we usually do it as part of our workup. And if it hasn't been done already, and if they don't do it, or if they're already on therapy, I mean, it depends on how much they're on, where they're living, If you're living in the northern part of the United States, you're not going to get as much vitamin D. If your skin is darker, you're going to absorb less vitamin D into your skin. So there are a lot of factors. How much outdoor activity you do, those will figure into what your vitamin D level is. But I think it's very reasonable to have your vitamin D level checked if you have AERD or a condition that's similar to AERD, and to get on enough therapy to get that level into the normal range, which is usually above 30.
And I wanted to jump in, not quite on this, but Andrew had asked a really nice question that I think is really important for the audience is how long does it usually take AERD to develop? So this one was very interesting to me from a standpoint of, I think part of this, and a lot of people have asked the misdiagnosis, the awareness, and we'll talk about that. But one of the challenges is these symptoms your symptomatology doesn't all develop at once. You don't wake up one day with asthma, nasal polyps, and aspirin sensitivity. So you're going to develop either the sinusitis with polyps first or the asthma first. And then it may be a couple of years, and John, you can jump in afterwards. You've got more experience than I have this. It may be a couple of years before you actually develop the next thing. So after the polyps have developed, 2 years later, you develop the asthma. So people still aren't putting things together. I had a wonderful woman the other day who she had sinus problems for about 3 years and didn't want surgery, and that was fine. We were trying to treat her medically as well as we could. And then about a year ago, she wasn't diagnosed. She said, I'm starting to wheeze a little bit. And we finally went for surgery. And literally 2 weeks before surgery, she said, I was taking Alka-Seltzer for the first time, and I had a reaction. So I literally was seeing this progression over a 3-year period. And that's part of the challenge that makes this a little bit of a diagnostic dilemma for us, is it doesn't all set off at once. So that's a big part from an education standpoint for physicians, is to make sure we recognize as we keep watching them that these things may be progressive.
I would echo what Nithin said. The process is something that evolves. We have seen patients who come in with just sinusitis in a limited area, mild asthma, and then a few years later have severe sinusitis. And then where they tolerated NSAIDs before, and all of a sudden exactly as he mentioned, they will all of a sudden now, not be able to tolerate them and will have an acute reaction. So yes, it does evolve. The natural history of the condition is it takes usually a few years to get the full, triad.
Thank you to both. Yeah. And our next grouping of questions is around AERD treatments, specifically medications and biologics. I'm going to add in the chat here, you can find even more information on what is AERD and what causes AERD at the Penn AERD Center website. So I'm adding that here in the chat now. That's pennmedicine.org or .edu /, /AERD Center. Our next question, as I mentioned, related to AERD treatments, this one is for Dr. Bosso. Which biologics have shown efficacy with AERD?
So there have been very few studies that have specifically looked at the AERD population. Polyps have been studied. CRS with chronic rhinosinusitis with nasal polyps have been studied. But there's very little data that's directly looking at a prospective analysis of AERD with biologics. That being said, what's out there is there's one study that was done, the one that really got Dupixent to be FDA approved, looking at what the effects of dupilumab were on chronic rhinosinusitis with nasal polyps. They found about 30% of the patients in that group had AERD, which is about what you'd expect. And they did a subset analysis of that data, and they showed that those patients did just as well as the patients did who didn't have AERD that were in that group. So that's kind of an extrapolation of a study. It wasn't like a study that just focused on AERD patients. But with that being said, the data looked just as good as it looked for patients who had chronic rhinosinusitis with nasal polyps who did not have AERD. There is a non-controlled study with omalizumab or Xolair showing effects on reducing inflammation throughout the upper and lower respiratory tract, the reliance on corticosteroids. And there is one study that was also done on 14 patients that Tanya Laidlaw did with mepolizumab. And that was a retrospective look at 14 patients, how they did compared to other groups. So, and that also showed some benefit. So all of them have shown some benefit in these uncontrolled or extrapolated studies. There have been no sort of double-blind placebo-controlled studies done, like there have been 4 of those done for aspirin desensitization. So we know that they probably do have an effect and do work in most patients. What we don't do is go to them as our first-line therapy. And the reason we don't go to them for first-line therapy is numerous. One is that we have had really good results with having one really good surgery and patients taking aspirin, which is something they can do on their own long-term and is a lot less expensive than going right to a biologic. And so when we think about the cumulative cost over one's lifetime, if the average person gets this condition in their 30s, you're talking about perhaps millions of dollars, being used for this, which may be unnecessary because, if you do it right the first time, you may not have to be on a biologic for the rest of your life. So this is something that the other thing is we don't have the same rigorous studies, and we also don't have long-term data. And so that's another issue. We have a lot of long-term data on it. We know that there's only a very small subset of people, probably less than 2%, that have serious adverse effects. So in terms of biologics, I'd like to see more studies in the future to solidify what we're already excited about, that the fact that for our most difficult patients, we have those available to us is something that I think we're welcoming as part of the armamentarium. But we're not necessarily throwing the baby out with the bathwater. We still have an effective therapy that, when used appropriately and in a coordinated way, works for most patients. So again, we have patients on both therapies. We have patients who are also on aspirin and on biologics. And so they each have their advantages and disadvantages. And so sometimes that's part of what we'll go over with a patient before we sit down and make a long-term treatment plan. And also some of it has to do with insurance coverage. And there are many factors, what kind of medical conditions you have already. Someone may be on other biologics for a medical condition, and maybe that may not be a good idea to mix in another biologic. So we really have a lot of, it's not a one answer fits all. But yes, there is starting to be some preliminary data showing that some of the biologics are effective. Unfortunately, what we also saw, because we were one of the main sites for the dupilumab study for nasal polyps, is unfortunately there's no continued staying power when you stop these medications. They don't really change the natural history of the condition, and they really have no long-term effect. Once you stop the therapy, within several weeks, things start going back to baseline. So I think that's the problem. I mean, the holy grail would be to find a treatment that interferes with the inflammatory process and has a permanent effect on that inflammatory process. And that's where we're going to talk about genetic treatments in the future, perhaps molecular therapies. We're not there yet. But so everything we have now is much better than what we used to have. And when done in the hands of people who know and have experience in how to use the medications, when to use the medications, which patients to use them on, then that's really the start. But I'm hoping that down the road, we're going to have even better therapies, and better studies. I think we will in the next few years have more studies on those biologicals, and you'll see how they really do long-term in these cases. But I'm encouraged, and we are starting to use them in selected cases. And again, this is what we do. We look at each case differently. So There was a question related to that I might as well just we might as well just bring in. Someone mentioned, would you recommend aspirin desensitization and going on Dupixent? So again, we have patients who are doing both. Do you have to do surgery prior to doing desensitization? The answer is almost always. Certainly you want the polyp burden and you want the sinuses to be in pristine shape before you would add in aspirin, because aspirin therapy prevents new disease. It doesn't get rid of old disease. So maybe not 100%, but the overwhelming majority of patients would benefit. And Nithin will explain what the other benefits of doing surgery are. One of the major benefits of doing surgery is actually being able to have topical therapy reach the tissues where polyps start. So you can't do that if your sinuses are all closed up. And so he would be better to explain why that happens. But and then someone else mentions here, what if you're already on Dupixent and then decide to get desensitized? There's no problem with that because they each have their benefit. They each reduce inflammation by different mechanisms. And there's some advantages to both. For example, if you're desensitized to aspirin, you're then cross-desensitized to other NSAIDs. And that's not something that can happen with any other biologic. So when you're on aspirin desensitization, even as little as 325 milligrams per day, which is the lowest dose for sinus effectiveness, you can actually take other NSAIDs. So and so some people elect to do it for that reason. Yeah, I mean, I have patients who are taking both therapies, realize that they both have their advantages and disadvantages.
Thank you, Dr. Bosso. The next question that we have is addressed to both of you. Why is there such a variety of responses to the same treatment among AERD patients?
Sure, I can go first here. So remember, this is not a binary condition. So think of it two ways. You have an intervention, and then you have the patient. From a patient standpoint, there is a wide spectrum of disease. Just like asthma, just like any type of chronic sinusitis, we use the word AERD and we immediately recognize that you're on the more severe spectrum of chronic sinusitis with nasal polyps. But of those patients, we see in our a huge variety. And that's part of also why there's differences with what John has on the amount of maintenance aspirin patients need. And we've got some papers in the works looking at different demographics that we're seeing who need less and who need more to keep their disease process at bay. But essentially, it's not binary from that standpoint. And then the other part that's important here, I think we've kind of hit home a little bit on it, is everyone assumes this treatment is the same. All right, I had sinus surgery and aspirin desensitization. There still is a wide variety there, as I even showed or we were talking about. Even us, we had the same treatment, but we just moved to a single center, and all of a sudden we had better results. So the point is, there's both the intervention arm that is a variety, and I think it is tough for patients to understand those differences, and I get that it is very challenging. But then you also have that spectrum on the patient standpoint as well. So between the two of them, you're really going to see a wide variety of responses and treatments.
And I
John, you have anything on there?
Yeah, to add to that, not only is there a spectrum of severity, but there are also these subtypes that we don't quite understand yet. So there are differences. And when we get a better handle on the molecular makeup of each individual AERD patient's tissue, sinus tissue, we're going to probably find that there are going to be groupings within AERD, clusters. And so we are doing that. We're doing what's called cytokine profiling, which, in the lab. And what we're hoping to do someday is to be able to say, well, this patient falls into AERD group 1, this one in group 2, group 3, group 4, and perhaps this patient would respond better to aspirin, but this one wouldn't, and this patient might do better with a biologic up front, this patient. So when we get a better handle on that, I think, but one thing I know from dealing with this condition for over 30 years is that all AERD patients are not the same. It's not one condition. There are variations. Between the variations in the type and the spectrum of severity, and as Nithin mentioned, other factors, that's why you're going to see different outcomes in different patients and different responses in different patients.
Thank you both. Next question for Dr. Bosso, and this is something that you addressed also a moment ago, but perhaps there's some additional detail here. What do we know about the long-term side effects of some of the newer biologics that are out there?
So we really don't have much more than 4 or 5 years worth of data on the biologic. The only biologic that we have more data than 4 or 5 years on is omalizumab or Xolair. That's been out. That was FDA approved in 2003. It was used in Europe a few years before that. So we have a little under 20 years of long-term data, and there really don't seem to be any major safety problems with that molecule, which I think is great. I mean, it's been something that we can say. But about the others, the most we have is about 4 or 5 years worth of data, which so far has been so far so good. There have been no major safety issues, but that's what we have. And so that some people would say, well, it's better than a brand new drug, but it's also not as good as something that's been out there for a long time. So I think it's somewhere in the intermediate stage, and time will tell. I'm not expecting anything horrible to happen, but again, things happen sometimes when the drug is out for a while, and that there are many examples of that. So I say I'm cautiously optimistic that we're going to continue to see the same safety profile in the long term.
Thank you. The next question for Dr. Adappa: do you see the price of biologics going down at any point soon?
No, I do not. These are medications that the pharmaceuticals have put major money into. And they, from my understanding, they're actually quite expensive to produce as well. So they're trying to get their money's worth. I don't know the exact pricing of Xolair, but we mentioned Xolair's been around for a while, and it is still a very expensive drug, being out since 2002, 2003, and it's still very expensive. So short of something happening in politics where there's some drug pricing control from that standpoint, I think these medications are right where the pharmaceutical companies want them to be, unfortunately, and they're going to keep them there, I think.
Thank you. Next question for Dr. Bosso. Zyflo is great for a while, but doesn't last 12 hours. And this patient has asked if there are any suggestions to keep sniffles and symptoms away before their next dose.
Well, again, I can't comment on individual cases, but I would say that I've heard this many times from many patients. So this is why we took this question, even though it has a sort of an individual flair to it, but it also comes up so often. So when that happens, it's a tip-off to me that the patient needs more therapy. So the Zyflo can be really, really excellent for patients who have AERD, especially for their asthma, but also to some degree for some of their nasal sinus symptoms. But when you get that history that it's wearing off in 12 hours, and if I don't take it on time, if I go into the 13th or 14th hour, I'm having symptoms, that tells me that the inflammation needs more than just that therapy. And perhaps the patient needs to be on aspirin or a biologic, or needs better surgery or something else. And so that really depends on obviously what's already been done and what they're already on and what they've tolerated and what they've responded to, et cetera. But just when you hear that, you know that, okay, maybe they're trying to use, there are very, very few AERD patients, almost no AERD patients who can be treated with a single entity. Almost everyone needs a combination of approaches or therapies, whether it be a combination of medications, a combination of surgery and medicine. It's one of those conditions where there isn't just one thing that you prescribe and you're done. And so Zyflo has been so underutilized. It's definitely an underutilized medication. And maybe a lot of that has to do with the price being so high. There's only two companies that manufacture it. It's not a high volume medication. I've heard all sorts of reasons for it. I really don't know the real reason. But the long story is, when it wears off, it means that you probably have other things that have to be treated.
Thank you. Our next grouping of questions also around AARD treatments. These ones focused on surgery. This first question for you, Dr. Adappa, can you please explain the difference in efficacy of some of the various surgical techniques that apply in the treatment of AARD?
Sure. So I think this one is important because it's been changing from a sinus world, our understanding of sinus surgery. So when sinus surgery first came to the United States, we're talking mid-'80s, the concept was open things up in a small, minimally invasive fashion. And if you open up the little openings, things will start to drain out okay. And lo and behold, your sinuses will get a lot better. And that works for some patients who have a little more of an infectious flair to their sinusitis to some degree. In a case like AERD, where it's all inflammatory, drainage is actually not, while it may feel that way for patients, drainage is not really the issue. The issue that then we started pushing for is what John started talking was topical therapy. We know steroids work, right? So steroids is like a shotgun anti-inflammatory approach. The problem with oral steroids is you can't take oral steroids forever because you've got lots of side effects. The beauty of topical steroids is that they hit the area it needs to hit, and they work by shrinking down the polyps in that area. Now, things like Flonase or Nasonex or those sprays in general, they don't get deep into the sinuses. Whereas topical irrigations, when we put rinses in there, they'll get in if the sinuses are open. So then we started changing our thought process, say, okay, we're not doing sinus surgery to open things up so things can drain out, but we're starting to do sinus surgery because my goal is to get those steroids in that don't have any side effects. So going to what Dr. Bosso said, these alternative therapies. So that was a big portion of sinus surgery. We said, okay, we're opening things up, let's get things in. Now there even is another shift is when we think of sinus surgery, and I apologize, I don't need pictures. If you think of your ethmoid cavities here, you have all these partitions that are coming down. So if you open up here, 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 now you can say, okay, my rinses should be able to get in, no problem. And that actually makes sense. But here's the problem. We know with AERD, all those little bony partitions have diseased mucosa on them, right? So the next phase of sinus surgery is what we're doing is we're actually removing all these partitions right up to that skull base. And so what you're doing is you're removing all this surface area and minimizing that already diseased mucosa. So what we're doing in effect on extensive sinus surgery is reducing that diseased surface area for you and then getting topical therapy to now that reduced area. So that's what we're finding is if you use that type of technique, we're getting much, much better results from an outcome standpoint. The problem is, Penn, we are spoiled. They spend a lot of money on us to get us the equipment we need because that's, very expensive real estate. We're, a millimeter from your brain, a millimeter from your eye, opening those sinuses up. But if in AERD, and I'm not saying all sinusitis, there's plenty of sinusitis that you don't need to do this, but in that severe form, we're finding if you don't have the ability to clean every last bit of those partitions out, from a surgical standpoint, unfortunately, you're doomed for failure. And we actually are even getting more aggressive. There's a procedure we're doing more and more for AERD, and you'll start seeing this in the publication, at least from us, where we do something called a draft 3 drill out, and not in all of our patients, just in some of our patients, where we're actually even combining the sinuses up here. So instead of being split to side, they're actually connected because we're finding a lot of the polyps start forming up here first. So up in that ethmoid skull base. So if we open up there better, we can even get that topical rinse in there better. And again, we're currently showing even better results from that standpoint. So the part of the sinus surgeries are very challenging is it's hard from a patient perspective to understand the differences here. But that really, if two people dictate the same surgery, there are still differences in what we're doing on opening up that ethmoid cavity, for example, or that maxillary or that frontal sinus. And again, not all surgery, but for AERD, topical access and removing every little hanging partition, you're just not doing as well.
And I can vouch, Michael, I can vouch for the fact that he gets rid of every partition.
The next question actually also for you, Dr. Adappa. Are nasal implants for polyps a successful solution for AERD?
So I think the nasal rinse, the implants we're talking about, the drug-eluting or the steroid-eluting implants. So essentially anything that has steroid on it topically that's not absorbed by the bodies are going to work. The whole challenge is, just like everything else, this is a chronic condition. So if you have a full area of polyps, you put a implant in there, you're going to get, I believe you'll get some results in most situations. The problem is that's only, it's got durable results. The second that implant stops eluting steroid, you lose all that benefit for the same reason as a chronic condition. So we've not been real huge on pushing for the implants because, we really think the topical, at least with the price point, the topicals make a lot more sense in making sure they're getting in. So there may be some situations.
We lose him.
I think we may have lost Dr. Adappa, and that's fine. What we'll do while we know he's going to be circling back to us. Yeah, the next question that we had is regarding the coordination of care. This was for both of you, and certainly Dr. Adappa will be able to add when he rejoins us. But why is the coordination of care between surgical care and medical care so important for AERD?
I think we've kind of been talking about that all along, Michael. We did in our introduction, and we kind of alluded to it along the way. I think it's so critical because you're taking two different skill sets, okay, and you're attacking one condition that's not basically following the rules of how someone was trained. So Nithin was trained in a certain way, with more of a surgical bent to his training, and I was trained with more of a medical bent. I look at molecules and tissues and mediators and pharmacology a little differently from the way he looks at things, and he looks at things in terms of anatomy, medicines reaching targets, being able to open up spaces. He thinks three-dimensionally. So we have different skill sets in how, and so I think that they're complementary when it comes to a condition that doesn't really have a sharp demarcation. And so there's things that I can do for this condition, and there are things that he can do. And some of us do some of those things better, but when we talk to each other, we kind of coordinate our skills. It just goes to reason, like with every complex disease, like cystic fibrosis, diabetic foot ulcers, having multiple specialists being involved and contributing what they know, and what they've learned and how they attack a problem from a different angle is just invaluable. And at least that's my opinion about why things work. I think it has to do with complementary skill sets. Nithin, I'm glad you're back. We're talking about the coordination of care and why it's so important.
Yeah, no, I mean, I can't, like I said, we have our own internal case study that we were telling you about from the distance to together, that it was one of those, when I saw the results showing that improvement on two people or two groups, because like I said, my rhinology group, we've got some great rhinologists. It's one of those duh moments, but it makes perfect sense.
Thank you both. Circling back to the previous question around nasal implants, Dr. Adappa, can you tell us more about that?
When did you lose me on the nasal implants? Was I just talking to myself for a little while?
It's possible. I'll reiterate the question. Yeah. Our nasal implants are a successful solution. Yes.
Got it. Okay, so basically we lost all of it. So I definitely was talking for about 3 minutes to myself. But nasal polyps, basically, we know what the implants do. The implants, I believe we're talking about the steroid-eluting implants. So the steroid-eluting implants, they're just like any other topical and they've shown not any systemic absorption, so you're not too concerned. But the problem is it doesn't have a durable response, right? So you will get relief from a polyp standpoint with the steroid there till the implant runs out of that elution of steroid. So once you run out, there's no durable results. Polyps are just coming back from that standpoint. So you really need a long-term topical steroid option. And so at least in the given circumstance, at least I can speak for Penn, I can't speak for every country. There's not a way you can get with insurance is that I could put an implant in and then you come back and see me 12 weeks later, I'll put another implant and you just keep going that way. So for us, unless there's like an acute flare up where we think we can get an implant to get the swelling down a bit, so then your rinses can get back in there very well with their topical steroid, we haven't found it as like a long-standing results. So it's not something we use in our practice. We don't use it immediately after surgery, and we don't typically use it later on just because it's something that it's a bit of at least for AERD, and I'm not speaking for all sinusitis, but for AERD, it's just a little bit of a Band-Aid, but it doesn't seem to provide us any like long-term durable results.
Thank you, Dr. Adappa. Our next group of questions are related specifically to aspirin desensitization. Dr. Bosso, can you tell us what aspirin desensitization is and why it works?
Well, aspirin desensitization is a process by which we give gradually increasing doses of aspirin to a patient who has AERD, and we do it over a period of 1 to 3 days, depending on which protocol you use. I have a 2-day protocol, about a day and a half to 2 days. And over a period of time, what happens is the cells become tolerant, and so the mediators don't get released. And so you may have small releases of mediators, but with repetitive use of a dose until, sort of graduating from step 1 to step 2 to step 3. If you have a glitch, you have a reaction, you'll repeat that step. And basically what happens is eventually the cells stop reacting. And so you get into that desensitized state where you're not releasing mediators, which cause inflammation. And that's when you stop reacting. So that takes time. It has to be done in what I call it the baby step process. And patients say, well, what happened when I took a full dose of aspirin or ibuprofen? I had this horrible reaction. And I said, yeah, well, you got thrown in the deep end of the pool. I mean, now what we're doing is we're going to be dipping our toes in and then our ankles and then our knees, et cetera. Not only that, we've shown that the literature has shown that after a surgery, the reactions to aspirin are much, much diminished. So that's another thing. Also, after surgery and with proper medical therapy and asthma being controlled before surgery and doing this over a period of a few days, the body can get used to that aspirin in a very gentle way, and patients do not have to be uncomfortable during the procedure. So what we find, and then there's a new twist to that, and we've been doing for the last not so new, it's 7 years, where we actually give increasing doses of a nasal spray that contains a medication in the aspirin family first to try to get the respiratory tract used to some low doses of non-steroidal anti-inflammatory drugs, and then we graduate over to low dose, medium dose, and high dose aspirin. So we make the process even softer. And since we do it about 6 or 8 weeks after surgery, the patient's in great shape going in. And so usually it's not as bad as what everyone may have this fear. Oh my God, when I took aspirin, it was so terrible. We had somebody last week who we desensitized who was so frightened because her original reaction was she was actually intubated. They actually had to put a tube in her and put her on a ventilator because her reaction to aspirin was so severe. I believe it was ibuprofen, was so severe. And she went through with it, but I know that she needed her hand held through it. And what we made her realize is she wasn't the same person she was when she was full of polyps. Her disease was uncontrolled. She was on no appropriate medications. But when we got her asthma treated, we got her completely cleared out by Dr. Adappa, and then we had her on some post-op medications that kept everything in the inflammation down. And then we brought her in and we did this and we tiptoed through the procedure. She had a very mild reaction that was treated within an hour, and she was not very uncomfortable, and it was all over. And she was like waiting. She just kept waiting for the dramatic, a dramatic event that didn't happen. So the truth is that that's what typically happens. If we do this in a coordinated way, it's not so much doing the procedure, is that knowing when to do it and how to get the patient prepped for the procedure. And that's just as important as doing it. And it's the same thing with surgery, So yeah, I mean, hopefully that explains what actually happens. And the second part of the question was, how does it work? That's a harder question because we're still looking at that. There's still a lot of studies on the mechanism. The general feeling is, and if you look at all the studies that show that this mediator and this cell was reduced, is that mast cells, eosinophils, leukotrienes, they're all downregulated during the process of aspirin. Once you get to the point of desensitization, the key players and the ILC2 cells, all the cells that release inflammatory mediators, they're downregulated. In other words, they're not releasing their chemicals like they were before, and therefore they're not creating an inflammatory environment. And the leukotrienes, which are the receptors for the leukotrienes and those chemicals that cause a big part of the misery, they're also been downregulated after desensitization. So when all of that occurs, you have a state where inflammation is at a low level and it's pretty quiet. And if you can keep it there by continuing to take aspirin after you're desensitized. And so that's how we think it works. But when I say we don't know everything, because tomorrow they'll discover another inflammatory cell that we didn't know existed and that was mediating some of this therapy, and it was releasing something that we hadn't discovered before. And we're going to find out that that's also part of what happens. So when I say we don't know, we know a fair amount, but we just may not know it all. But from an overall standpoint, it's quieting down of the inflammation.
Thank you, Dr. Bosso. I'm looking at the time, and I see that we're nearly at time already. We've had a lot of really terrific information. That doesn't mean that we have to wrap up right now. I think we have time to highlight a few other questions. The next two, these are follow-ups to questions regarding aspirin desensitization. The first, Dr. Bosso, is what happens if a patient stops taking aspirin after desensitization, and will they get polyps again?
That's a good follow-up question. First of all, if they don't take aspirin for more than 48 hours, they'll start becoming sensitive again. So those inflammatory cells that were downregulated when you're taking aspirin after desensitization, when you no longer take it, those cells will start releasing their chemicals little by little by little. And after about 5 days, they'll be back to where they were prior to the desensitization. So I always tell patients, don't go more than 48 to 72 hours without taking your aspirin. Otherwise, you're pretty much going to be vulnerable to a reaction. So that's the immediate consequence, is that you're no longer going to be, and also you will no longer be able to take aspirin or that's once you're not desensitized, and you could be vulnerable to a severe reaction. With time, when you take away that anti-inflammatory milieu and you have inflammation starting up again, what the natural consequence is, polyps will eventually develop. Now, it's not going to happen in a day. It's not going to happen in a week. But within a few months, you could start seeing the formation of polyps. And so polyps are basically inflammation that occurs underneath the sinus epithelium. And that inflammation balloons up, tissue fluid is released, and you develop a polyp. So it takes time to develop a polyp, but that's what would happen especially if the aspirin treatment was successful at keeping the inflammation down. Unfortunately, it's not going to be an immediate effect where you'll develop a polyp, but within a few months, you will start seeing the beginnings of polyps. And in some patients, again, there's a spectrum. Some patients will develop them faster than others. So you'll see that some patients will have an off where you might see them 2 months later and they're back to where they were. Some patients may take 3 or 4 or 5 months, but unfortunately, there's no durable effect of any therapy, biologic, aspirin, or any other medical therapy. It's one of those, it's a condition where the inflammation doesn't take a holiday. And so therefore you cannot take a holiday. You have to be on top of it. You have to continually treat it. And so, it doesn't take long to lose the battle, unfortunately. Again, some people will have longer than others, but the focus is it's like a constant war. You can't let up your guard.
I think the other part that's important here is this is a chronic condition. So the example I give my patients when they, I think it's a reasonable question. Like, I want to be done with this. I'm treated. I feel better. What can I do? But, the example I typically give to my patients is I look them in the eye and say, hey, when they ask me, do I really need to take this forever? I say, do you know what diabetes is? And just about everybody nods their head and says, yes, I've got a family member with diabetes. I say, if a diabetic walked into a doctor's office and said, Doc, I'm so sick of these medications, let's stop them. Is there something else we can do? You can't. The diabetes, it's a chronic condition. Now, the difference there is the diabetes will kill them if they're not treated, but still the point is these are chronic conditions. So any therapy we have now, short of some research that can change the genetics, which we don't have, is a chronic treatment. Now, everyone's going to be different on how much treatment they need, but that's the biggest point, unfortunately, is these are a chronic condition. That means they need chronic therapy.
Thank you both. Dr. Adappa, another of the follow-up questions related to aspirin desensitization. This patient asks, I am aspirin desensitized, but I have no sense of smell. Would using a Dupixent also help in that regard?
Right. So I thought this was actually a great question. So let's kind of go through sense of smell a little bit. We're not going to go too detailed, but basically loss of sense of smell, which the majority of AERD patients have, there's two aspects to loss of sense of smell. So there's number one is literally the polyps that are blocking the olfactory cleft. So the olfactory cleft is an area just between your septum and your middle turbinate, and there's what we call olfactory villi. So basically you have a bunch of your smell nerves there. And so the polyps and the mucus surrounding the polyps are physically blocking that area, and so you don't have a sense of smell. What also happens, unfortunately, is over time, and it's not totally well understood, but we think this inflammation either affects those neurons or something in the cortical pathway to tell your brain what that sense of smell is. So over time, your top end function of your sense of smell starts to diminish. So meaning if you had polyps after year one, you clear those polyps out, you'll have probably your baseline sense of smell back. If you waited, and I'm making up numbers, I don't know the data, and I don't think anyone knows the data. If you wait 5 years and you get your sense of smell back, it won't be anything near what it was 5 years ago. It'll be down. So at some point over time, if you've had polyps long enough, no matter what you do to clear every last bit of polyp out in that area, no smell is coming back. Usually there's no real study, like tests or anything like that to really tell you that. The only thing I typically ask my patients is, when was the last time you were on prednisone? And they'll typically, as you know, AERD patients will say, a month ago, 3 months ago, something like that. And I say, did you get any smell back at that point? If they say nothing, I say, listen, I'm really concerned with your history that you're probably not going to get it back. But if they say, I got some stuff back, then I say, okay, well, we got a shot. Now, going back to this actual question then is, if you're desensitized and you have no polyps up in that olfactory cleft, the mucosa is clean, and you're saying, I have no sense of smell, Dupixent's not going to make any difference whatsoever. Now, if we say that, hey, look with an ENT looks with an endoscopy and looks up there and says, hey, you've got polyps there, then there may be a shot that if you reduce those polyps in any way, shape, or form, that you may get some smell back. But again, this still goes back to that baseline question, is how long have you been without smell? I hope that makes sense. But I thought that was a good question to kind of understand our thought process there.
Thank you, Dr. Adappa. That is really helpful. Our last question related to desensitization is for Dr. Bosso. Will desensitization affect my reactions to alcohol?
Yes. I mean, we did that study here at Penn Medicine in conjunction with people at Scripps Clinic. Andrew White and myself authored that study, and I'm proud to say that about 86% of our patients who were desensitized did have an increased tolerance for alcohol. Again, we're not advocating that people were doing this because they can drink. Okay, I'm not telling you don't take that message away. But I think part of being, part of the quality of life issue with the reduction in quality of life for at least maybe the majority of patients who have AERD is, even on a special occasion, I can't even have a glass of wine or a glass of beer. And it would be nice to be able to do that without having to pay the price of being miserable for several hours or even a whole day. And so we did show that before and after 3 months after desensitization, about 87% of patients were able to have an increased tolerance compared to before. And that was something that was a corollary to when the first study, which showed that about 75 to 80% of patients who have AERD are intolerant to some degree to alcohol. And then my corollary question was, well, what about if we desensitize them? Will they have an improved tolerance? And so although we don't understand all about the mechanism, it does come down to downregulation of what we think are cells like called basophils, mast cells, and somehow they seem to be affected by the alcohol. We think that there are some polyphenols called catechins, which may be playing a role in the mechanism of why this happens. But the truth is that, yeah, I mean, it's one of the little extra perks. Some people it may not be a motivation for some people. And again, I'm not advocating that people go out there to do this for that reason only, but it can be a nice thing to have, to be able to have a glass of wine once in a while without having all the symptoms.
Of course, that was one of my favorite papers. Actually, it was a fun paper to look into. But one question we're getting a lot of on the feed is about COVID. Yes. We haven't answered COVID. Honestly, it's just nothing out on COVID. I'll jump in on my 2 cents, and then John can as well. From a sinus standpoint, we haven't seen anything specific with COVID. I mean, obviously there is, this loss of sense of smell, et cetera, but I have not appreciated any noticeable predilection in either AERD or in my chronic sinus patients that would indicate that they're any more susceptible that I've seen at all, honestly. John, would you agree with that?
Yeah, we haven't seen increased sinus disease. In fact, there was a paper that I just saw that was just sent in my email today that I didn't get a chance to read, that discussing chronic sinus disease and COVID. And so it doesn't look like chronic sinusitis of any form, including AERD, seems to be worsened when you get COVID. COVID seems to attack other areas like the lung, and so and not even the same exact areas that asthmatics are affected by. But from the standpoint of COVID, with the exception of the area of the sense of smell, which seems to be particularly vulnerable, the actual sinuses, we haven't seen that. And the other thing is that when COVID first, started happening, we were of the mindset that moderate to severe asthmatics would be at the very high risk for COVID, or that they would have more severe disease. And although we still feel that there's some vulnerability there for the severe asthmatics, we're not seeing that. And there's some controversy there about the numbers and the data, and it's not clear that that's the case, that there may be some protective effect that's occurring. So again, there is controversy. We don't have the bottom line answer to that. But it's surprising that that it's not really having a major effect. And perhaps the inflammation that's occurring in AERD or in asthma could potentially have some protective mechanism that we don't understand for these patients. But again, surprisingly, not what we expected.
Yeah, thank you both, Dr. Adappa and Dr. Bosso. We did see that was a question that came through a few times, so I think I speak for the audience when I say that was something that we all wanted to learn a little more about. Our final question for the night is around AERD research. This is for both of you. What research has recently been conducted or is currently being conducted at the Penn AERD Center?
Right. So we're doing, we've got a lot of research going on. I can go through some of the clinical stuff. So basically, the big things we're looking at is we're looking from an outcome standpoint of looking for what everybody's looking for is durable results. So essentially, we're looking at our outcomes, we're publishing our outcomes, but we want outcomes not just 6 months, a year. We want to keep looking at these patients 5 years, 10 years down the road. So we've got a pretty robust database of all our patients that we're really taking a lot of information on both their asthma and on their polyps and their tolerance of aspirin. So we're looking at that. We're looking at the overall corticosteroid usage afterwards, and we just published a paper on how a significant decrease in both the need for medium and high dose inhalational steroids as well as oral steroids as well. So we're really looking at a lot of these side effects and what we can reduce there. So these are the things we're looking at. From a surgical standpoint, I kind of alluded to it a little bit we've even gotten a little more aggressive on some of our surgeries that we're doing with these drill outs and looking at the outcomes to see if what we're, at least our clinical gestalt, is kind of going through. And John, I think you can probably talk about some of the basic science as well.
Yeah.
And I'm sorry, before you go there, one other thing that's important, is we've got a pretty robust tissue database. So we've got what we call a biorepository. So if a patient agrees, when we do surgery, we take a portion of that tissue and we actually bank it in a tissue bank. And we're doing a lot of the experiments John will talk about in the tissue. And we're also saving the tissue for future experiments if we find future therapies that may work better for us.
So some of the things that we're going to be doing in the future with that tissue are genetic sequencing. We already have started looking at viral signatures to see if there are any particular virus or cluster of viruses that seems to be more likely to promote this condition or start this condition. We're also looking to see if there are subsets of different exacerbated respiratory disease patients by molecular analysis, the cytokines, the inflammatory chemicals that are released. We mentioned vitamin D. We're also doing we're doing a clinical trial now with ephedrine, which is a thromboxane blocker, which blocks one of the pieces of the pathway. There's lots. And again, we're always, we have our research meeting once a month and we're looking at, what we can do to all new ideas, related to both basic science, clinical science, and translational, which means the bridge between the bench and the bedside. And it's exciting. It's exciting times. And I think that, we're just starting here. We're just getting started, we're just getting started on what we're going to know, breaking ground and just scratching the surface and understanding this process.
Yeah, thank you so much, Dr. Bosso, and thank you, Dr. Adappa. I think we've all learned a whole lot tonight, and thank you to everyone who submitted questions for the docs. We may not have gotten to answer all of the questions that we received for tonight, so we may look to address those questions and others in a future Q&A event upcoming. And so also, for any questions that are related to really specific, personalized patient care, we encourage you to speak with your provider, or if you'd like to schedule an appointment with either Dr. Bosso or Dr. Adappa or a member of our team to discuss in more detail. So if you'd like to schedule, you can visit pennmedicine.org/AERD Center for more information. And again, thank you so much for spending the evening with us tonight, and we wish you all the best.
And Mike, one plug there. If you go to our website, Dr. Bosso and I spend a lot of time on these educational videos that essentially kind of simplify everything. So if you have somebody, physicians or friends or family who want to learn a little bit about it, just check out our website. We actually spent a fair amount of time. There's like 4 videos up there that I thought were pretty good.
Yes, absolutely. Lots of terrific information there.
And on our website, we'll be posting more about the research papers that we've published, a whole number of them in the last year or two, and they'll be linked to the website if they're not already. Right, Michael?
That's absolutely right. We'll be adding those as well. And then also related to questions around COVID, Dr. Bosso also has created a video around some concerns for allergy as it relates to, as it relates to COVID-19. And also we have content in addition related to smell loss and COVID-19. You can find all that information at pennmedicine.org or also at the Penn Medicine YouTube page.
Great.
And thank you again. Have a great night, everyone.
Thank you, Michael. Thank you, everyone.
Take care.